In a recent report, 51.3% of patients cited convenient, easy access to care as the most important factor in their healthcare decision-making. It topped brand reputation, quality of care, or even insurance coverage. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hetterly, senior writer at AHA and your host. Hospitals and health systems understand patient desires and are reinventing themselves by providing healthcare and wellness in new venues, meeting people where they are. Examples include home health services and monitoring, telehealth, clinics located within the community, and wearable monitoring devices. The following AHA-sponsored discussion, Healthcare Without an Address, was presented at the 2019 Aspen Ideas Health Festival. It explored how we're adapting to this new push beyond traditional boundaries, and what that means for affordability, patient outcomes, and the care experience. The four participants were AHA board member Brian Granulotti, President and CEO of Atlantic Health System and AHA's board chairman, John Haupert, President and CEO, Grady Health System of Atlanta, Georgia, Dr. Sam Sutaria, Chief Operating Officer of Tenet Healthcare, and Mary Jane Worth, AHA's Executive Vice President and Chief Operating Officer. Let's join them in Aspen.
I'm Mary Jane Worth. I'm the Executive Vice President and Chief Operating Officer of the American Hospital Association, and we really are pleased to be sponsoring this session and to be a sponsor of Aspen Health Ideas Festival for the third straight year. I know we greatly benefit from the conversations, the stimulation, the ideas that are shared, and be very pleased to be part of this discussion. I have some great individuals here who serve as our panelists. Directly to my left is Brian Granulotti. He is the president and CEO of the Atlantic Health System, one of the largest healthcare providers in New Jersey. And Brian is currently the 2019 chairman of the AHA Board of Trustees. Then we have John Haupert, president and CEO of Grady Health System in Atlanta, Georgia. John is also an AHA board member and chairs our AHA Committee on Health Strategy and Innovation. And then we also have Dr. Sam Sutaria. He is the Chief Operating Officer of Tenet Healthcare, and he recently came to Tenet after 18 years with McKinsey & Company, where he was a leader in its payer-provider practice. So we're really thrilled to have the three of you here. Before we delve into the subject, I do just want to set the stage just a little bit. First of all, the AHA represents nearly 5,000 hospital and health systems that not only provide high-quality, wonderful, stellar acute care, but clearly are providing services across the continuum and increasingly without an address into the communities. And as you know, in this wonderful country, one size doesn't fit all. We have all sorts of shapes and sizes of communities, and therefore the attention to what communities need and how we deliver care is very much a local issue, while we also try to make sure that we're meeting the AHA vision, which is of a society of healthy communities where all individuals reach their highest potential for health. And we see that not only is it about healthcare, but also promoting the health so that all individuals can reach that vision. And so we're going to be exploring a little bit about how our membership and across these three systems are really innovating and transforming rapidly in this very challenging environment to make sure that we're providing the highest level of care, but also the most valued care with the best outcomes at an affordable cost. I do want to just quickly touch on the notion of the basics of access and coverage, because obviously that is key as far as promotion of health, but also given the political landscape. And I know I've been to a number of sessions here already where the whole notion of where are we going with universal coverage has come up. And so we do want to address it a little bit before we delve into the bulk of this. So just a quick word about Medicare for All. And our take at the AHA is this: it's the right goal, but the wrong path. But we get it. Medicare for All really is a cry. It's a heartfelt cry from individuals around the country, and we really do need to listen and understand it. It's a cry for improving the system, to move to health care without an address and to promote health. It is a cry for expanding coverage so everyone has access. It's a cry for relief from unreasonable co-payments and deductibles, and it's a cry for dealing with long-term care, and it is a cry for ensuring that protections will be there when care is needed. And so we hear that, and just as Catherine Sebelius, who was here 2 days ago, she made the point that the groundwork for much of what is wanted by individuals across this country was set forth in the Affordable Care Act. And so we do, too, believe that working with the existing law of the land, the Affordable Care Act, making the improvements and making sure that that program is strong is the better way to go. But Brian, I want to turn to you for a little bit of an expansion on that. You are the current chairman. We have the whole audience of the hospitals and health systems, no pressure across the country. But can you talk to us a little bit about what that better way might look like?
Sure. So this morning, when I was leaving the hotel, I got on the shuttle, and I was in there with one other person, and she and the shuttle driver were talking about healthcare. And he was talking about how difficult it was at his income level to really access healthcare, access payment for healthcare. So you can't get away from this issue. So we have a system right now which really was partially corrected through the ACA. Last year at this event, one of the most moving sessions that I attended was with all of the committee chairs that were in place when the ACA was passed. They were all there. First time they were on stage was over at the Jerome. It was at 4 o'clock in the afternoon, and the room was overflowing. And the message that they gave us was that they were able to pass what they passed in a condition not dissimilar to the condition that exists today and existed over the last couple of years. But they also knew that they needed to continue that work because it was a start. It wasn't a finish. And their disappointment, and you could see it in their faces, and you could hear it in their voices, was that life went on in Washington. Things moved on. So when I take a step back and think about this, what we're really talking about is how do we continue what was set in place, knowing that it's very imperfect. Because the ACA was about two things. It was about insurance coverage, and that's the one that takes all the air out of the room, right? That's where all the debate is. But it was also about delivery system reform and enabling experiments throughout the country to occur. And you're going to hear some of that in our conversations today. And in my travels around the country, I am seeing that mobilized right now. And I'm seeing access improve. I'm seeing people actively work on lowering per capita spending in their communities and providing better health. So what we need to think about doing right now is to continue that effort and really continue to provide better care for America. And it's to continue pushing on Medicaid expansion. You know, we've got 20 more million people in this country now insured than there were 5 years ago. But we still have millions and millions of people who don't have that. We also need to make sure that it's easy to get access to exchanges, and we've got to stabilize that. And we've got to make sure that those enrollments are moving forward and not stifled. And most importantly, we've got to keep an employer mandate, because this is all about the math. It's all about the math and how do you make that work. So at the AHA, what we're talking about is how do we continue what was put in place, knowing it was imperfect, but not turn everything on its side, because in the end of the day, that driver, his final comment was, you know what though, I'm in a good place, I can now get care, and I'd hate to see that change.
Yeah, so thank you for that. And I think the important point about the delivery system reforms and provisions that were in there to really spur innovation and moving towards value is a key part of that. So let's use that as a pivot to now talk about the tremendous work that's happening across the country to meet those individuals' needs, to go well beyond the walls of the hospital, to provide health care without an address. And if I can get started perhaps with you, John, you serve a very vulnerable population within the city of Atlanta as a safety net system. And, how do you wrap your head around health care without an address with the unique, challenging population that you serve?
Sure. So just a little bit of background. Grady Health System is the largest safety net provider in Georgia, fifth largest in the country. We happen to be in a state that has not expanded Medicaid nor taken advantage of any of the waiver programs to bring the uninsured into some form of coverage. And so at Grady, within our health system, 30% of our patients have no form of coverage whatsoever or no access to coverage. And so are purely fall into our charity care policy. 50% are either Medicare or Medicaid, and only 20% are commercially insured. And so we have had to, over the years, as a super safety net provider, envision how we can reduce and continue to reduce the cost of care at the same time improving health. And so this whole topic of healthcare, wherever it can occur, is really close to us. And so I'll just give you a few examples. Our biggest goal is to move as much healthcare provision as we can into primary care medical homes located throughout the market we serve. We currently have 8 locations, multi-specialty, lab, radiology. But what we've done is those are led by primary care physicians. But instead of being an episodic care center, they are a proactive hub for managing health in the communities in which they're based. So each primary care physician has a team that they oversee made up of a PharmD, a doctorate level pharmacist, a nutritionist, a behavioral health worker, a care manager, a social worker, and a patient navigator. And that team cares for approximately 2,000 patients, each team, and is supported through the use of an AI product that we have been working with a company called Javion to be able to know where the highest risk patients are and what their current health status is. We build into that model socioeconomic factors, 20 different socioeconomic factors that help us judge risk for that patient. But by doing that, we're able to care for patients holistically, including their mental health and medical needs in the communities in which they live. Of course, a lot of that is not funded, but for us, it helps us to control the cost of care and to significantly reduce the utilization of the emergency room as a primary care location.
Yeah, thank you for that. I love the notion, and we're hearing more about this across the country, about screening for those social determinants right at the get-go, and then really having that multidisciplinary approach.
Mm-hmm.
It's not just the physical medical needs. John, you've had a local market. Sam, if I can turn to you, Tenet is a major national healthcare company. You have a fresh set of eyes, being relatively new there, and you serve many communities. How does Tenet approach this?
Yeah, the first thing you have to realize if you operate in the number of markets we operate in, and remember, we have 50 health system partners in the country as well, from the standpoint of what we do in our ambulatory platform, you cannot be everything to everybody, right? So from Tenet's standpoint as a core, what we've figured out is rather than thinking about this in terms of assets and markets, which is almost a dehumanizing set of terminologies related to what we do in healthcare, I have upwards of 10 million patient encounters that we're managing in some ways. I have 35,000 physicians and caregivers that we are trying to engage in what we want to do. I have over 2,500 operating rooms, 2,500 ICU beds, about 100 and something emergency departments, 100 and something urgent care centers that I have to link into that care network. So what we spend a lot of our time doing in management as we look at what Tenet will be going forward is figuring out what within the healthcare value chain can we do best and contribute in our communities. For us, that is largely high acuity specialty care. And so when we think about high acuity specialty care, you get into vascular disease, you get into bone and joint disease, you get into neurological disease, you get into a variety of other things like that, and you essentially build a platform that brings in a channel of patients, but gives them the opportunity to stay tethered to the system no matter where they are. So your whole point around healthcare without an address, I want to bring to Tenet the sickest of the patients in the communities, and therefore my investments in primary care are not broad, because I don't do that well, but my investments in primary care are designed to take care of those who have chronic illness, and figuring out how to build a model for them with good access, good connectivity, that allows them to work in a continuum with us in order to get that care. And then there are other models which we leave to others from a partnering standpoint, because we just can't be everything to everybody with the breadth that we have.
Yeah, great. We're going to come back to that kind of partnership notion in a little bit, which is so key to healthcare without an address. But Brian, you're doing a lot with Atlantic Health System and New Jersey, but you also, again, have that perspective of representing the AHA and listening across the country to the innovation and transformation that's occurring. What's happening in New Jersey and the rest of the country? Round us out.
Yeah, so it's interesting having this opportunity to see so many of our members and how they're approaching things. And I really appreciate your comment about focus, because I think it's different in every market. It's pretty amazing, particularly in our rural settings. We're seeing the creation of healthcare deserts in this country if we're not careful. And so we're seeing a lot of innovation going on in these rural settings, but we're also seeing regulation get in the way. We're seeing a lot of desires to innovate, but we don't necessarily have the enabling conditions that allow that because of the way our payment systems are structured. So what I see and what we're doing at the Atlantic Health System, and the Atlantic is in northern New Jersey. We serve a market of a little shy of 5 million people, and we actually count differently. So when I got there 4 years ago, I asked the question, how many unique individuals do we touch in a year? So 6 months later, our data people were able to come back and determine from our ACO data and from our primary care practices in hospitals, et cetera, we were touching about 700,000 of those 4.9 million people. So our objective became, how do we increase that by 2020 to touch 1 million of the 4.9 million people? And so our strategy was to distribute sites of care. So we have over 400 sites of care. But more importantly, our strategy was to lean into the experiments that are enabled through the ACA and others, like ACOs. We have some of the largest ACOs in the country, and we're getting great performance in terms of shared savings on that. Patient-centered medical homes, as you all talked about. But then use that as a platform to fundamentally change the way we approach delivery. So I can't tell you how many beds we have. I don't know. That's probably not a good thing for me to say publicly. I can't tell you how many ED visits we have, because I don't pay attention to that. But I can tell you the percentage of care that we retain in our clinically integrated network. Because for health systems like ours, large regional healthcare systems, that's part of the financial equation. Because while we are actively taking out unnecessary utilization in the system, in order to create a glide path economically, we have to make sure that as we touch more people, that they have the confidence in us to retain the care within our system that they need. And that's really what we're trying to do. And I'm starting to see that across the country in other large regional systems.
Yeah, I think the conversation is definitely, it's very similar to the ideas discussion here of the what-if scenarios and what if we changed our mindset and had different metrics and approached things differently. And one of the approaches that I hear about across the country is really that new digital front door, also as a new way to have healthcare without an address. And Sam, I'm wondering if I could start with you to talk a little bit about some of the approaches with technology and telemedicine to move in that direction.
And let me build upon what Brian's saying, because I do think we're at a crossroads with respect to what technology and consumer choice can do for us in healthcare in the US. So the reality is there are two fundamentally different models of healthcare consumption that I think could exist in the future. One is an integrated model. We've sort of been talking about an integrated model whereby those who are in the business of providing healthcare, or health even of some sort, believe that tethering those episodes of care together for continuity is a good thing, okay? And intellectually, that sounds very good. There is a completely different viewpoint that exists out there, which is what you live in all of the other consumer choices you make, which is actually the consumer is best positioned to choose what is of highest value to them in all of their encounters, and actually the fragmentation of care is better, meaning specialization of each type of care that you need. An urgent care center should be run by somebody who's expert in that. A hospital should be run by somebody who's expert in that. Primary care should be run by somebody who is expert in that. And as consumer choice grows, there is a risk that care fragments rather than integrates even further. You have to decide in some ways which model you believe in, but more importantly, which model will move the care outcomes that we're after forward given the expenditure we make in healthcare. And I would tell you that the healthcare economy has not figured this out, because in the world we live in, there are all kinds of organizations that will cherry pick various services out of the hospital campus or out of a surgery setting or out of a doctor's office in a very pure play type of network. Most of that is built upon technological or service innovation that they're taking advantage of in a narrow slice of care. So again, I think one of the things that really, I think, is important from the standpoint of where regulation and, I think, largely speaking, patient preference moves, is deciding which model we're going to move forward in this country. And that's not decided, in my view. So when you come back to technology, again, I think about the technological investments we're making, especially with respect to digital, very simply. You can digitize operations, you can digitize consumer interactions, or you can digitize the payment environment. Those are basically the three things. If you look at the banking industry, if you look at financial services, that's what they've done, and we're behind. So we're starting in the area of digitizing payments. We have a business called Conifer. We process about 25 million patient encounters every year. With respect to payments, we actually have a patient relationship because we're providing them the information in this incredibly confusing landscape of what does a bill mean in healthcare. In some respects, you would think, well, why does that kind of a business even need to exist if things were simple, easy? But they're not. And so we're very focused on digitizing the payment environment and being innovative in that area. The digitization of consumer engagement and operations is a little bit more difficult. So I'll just give you two quick examples. Look, from an operations standpoint, if you were to go to a ball game, you would now find a cadre of statisticians in the bullpen with the coach and players today, driving decision-making between inning 1, 3, 5, 7, and 9, literally. It's amazing that we have much higher value real estate in what we run, operating rooms and other things, and don't necessarily have that kind of capacity. We're not there yet, right? So we look at it on a weekly basis, not an hourly basis in some ways. In terms of real decision-making, we're trying to get there with technology. On the digitizing consumer side, it's a complicated environment because there's so much noise flowing at the consumer. Our focus has been what I would describe as more B2B telemedicine, dealing with the things that we do in high acuity, so stroke networks, for example, so that people, and I agree with you, no one's going to recapitalize the rural healthcare environment with new hospitals. It's not going to happen. But providing that access digitally through telemedicine platforms to ensure that a reasonable quality of care is provided and transfers are made when needed, serve both sides very well, and so we're focused on things like that. What we haven't figured out so much, at least in our environment, is the B2C component of where we should invest. So we dabble, right? We dabble, but I'm not sure we're having an impact.
Yeah. So are either one of you moving beyond dabbling in technology?
Well, I'm one that has a lot of hope and faith in the future of AI and what it can do to help us manage health better. I think there's a lot more opportunity than we've realized. We are very deep into this partnership I mentioned with Javion, to the point where our community ACT teams, psychiatric ACT teams, get a printout every morning out of the system that tells them, based on about 7 billion iterations of that patient's information, who they need to contact that day, and then who through our mobile program needs to be visited that day, based on did they fill their prescription, did they show up for their appointment, their lab values came back and were X, and all of that comes together to be able to make that happen. So from a population health, improvement of health point of view, it's way beyond the clinician's ability anymore as an individual to process all of that and to make that decision. We are using telemedicine and have developed a statewide stroke network, where we provide the oversight and assist with the clinical decision making for 70 different hospitals around stroke care. We use the backbone of our poison control center, statewide poison control center, to do that. Grady is also, for better or worse, the largest provider of mental health services in the entire state of Georgia. We serve a 2-county area that is primarily the city of Atlanta, but sadly we are the largest provider for the entire state of mental health services, only second to the penal system. And so we have had to really invest heavily in telepsych to be able to fulfill our mission, but also back to this statement about getting the care away from the hospital, getting the care into the right hands, and using the right type of provider to do that. We now do that throughout the Atlanta metropolitan area with what we call ACT teams. And those, though they know where every one of their patients are, even if they know if they're under which bridge, they are able to find them, contact them, and maintain that contact. So that's not even in a location, that may be wherever they are for that day.
Mm-hmm. Great. You want to add to that, Brian?
Yeah, I think the investments that we're making now are far different than we were making a decade ago. Our investments in technology, at its core, is a common electronic health record, so that as we think about care outside the walls, we make sure that we connect that care, so as that patient interfaces in different ways, that common record is there. And that is not a small feat to do in these organizations. And then how do you connect into community physicians? Because our physician network, which is over 4,000 physicians, only about a little less or less than half of them are actually employed within our system. So we still have a community-based system of care. The other investments we're making, as you described, were how do we use now this data that we're collecting, and also the claims data that we're collecting. In each of our managed care contracts now, the bigger argument is around getting data from the payers. The economic arguments are a little easier, believe it or not, because we have the ability now to integrate clinical and financial data to do some of the things that you're describing, but also build on that. So the investments we've had to make in data scientists and others have been extraordinary, and we have a whole different group. And then the third piece, to the point about how do you touch a consumer in a different way, one of the things that we really had to do in our organization are bring in people outside the healthcare industry who had the experience of dealing with consumers, and one of them was right there taking a video of me, who had really no healthcare experience. And she's our chief marketing officer, but she knows how to connect with consumers in a different way. So the skill sets that we've had to bring in to do this, so this isn't the healthcare system we were all born in. It's much different today, and it's a journey.
Yeah, I in listening to the three of you myself, and I've had the privilege of knowing all of you for a while, I mean, you really are diverse perspectives here. and reflective of what's happening in the environment. Very different approaches, different business models, but commonalities of focus on the individual, the best care possible, the best value that's being provided, and understanding what's within your wheelhouse. And there isn't just one answer to that. It really is very different. But one of the other themes that you three have already touched upon and that I hear around the country, consistent with what we're talking about at Aspen, is this notion of partnerships and this sense of knowing what you're good at, what you need other partners to. And John, you were starting to touch on a little bit of this, but Grady has only so much resource yourself, and you've really had to tap into thinking of partners in a very different way. And as we're thinking about healthcare without an address, tell us about some of what you've done, and we'll hear from the others as well.
Sure. The type of institution we are lends itself to being a convener within the community. And so when we talk about issues around mental health, we know that we can't do everything for everybody, back to your statement. But I feel we have a huge obligation to bring together the entities and the expertise that can help build this robust network for the population we serve. And so we have taken on an ever-increasing role in the convening of the different partners and different parties that can help us address certain disease processes or certain diagnoses. And so we do spend a lot of time in the convening and discussing and facilitating business, but it has yielded incredible benefits in helping build either local or regional networks that help address certain disease processes. One fact I left out up front is we are a closed medical staff. We are a teaching hospital. 100% of our physicians are either from the Emory School of Medicine and or the Morehouse School of Medicine. There are 1,500 attendings and approximately 2,000 residents, which is, I saw the physicians' faces light up. That is adult daycare at its best, isn't it, Nikki? Yeah. So it is a bit of a chaotic environment, but it allows us, when we're dealing with we're approaching that all together, and we have the expertise of those medical schools and the clinical capability, it makes that job of convening easier, and especially within our community versus it, Brian was just talking about half of their physician practices are employed, half are community-based, and that makes that a lot harder.
Although having come out of academic medicine, I'm not sure.
Well, yeah.
Yeah. Sam, do you want to talk about your perspective about finding other partners to really kind of work in doing what everyone is best at?
Sure. First of all, I don't think the healthcare delivery landscape has ever been short of partners. Those who provide healthcare have always had partners in what they're doing. This has never been an industry that owns everything, controls everything, delivers everything on its own. I think the question that we're all grappling with today is much more about, are these transactional partnerships or are they strategic partnerships? And how do we actually utilize and choose the partnerships together that are going to create value? So I think for a very long time, these partnerships in the industry were mostly transactional, okay? And I'm not sure that's actually serving the goal of innovation and improving healthcare outcomes best. So from our standpoint, we have lots of partners, right? We have lots of partners that are customers, and those customers are our partners in what we do with respect to our ambulatory business, where we have 50, 55 different health systems that we work with, and we provide ambulatory solutions to them because we're better at doing that, and they're better at running their acute care hospitals and focusing on community engagement. And that's a great thing for us. It's a great business. It lowers the cost of care in communities. It provides an alternative, better service setting. We're very proud of that business. I think I mentioned earlier, we have a payments business that takes a lot of what is back office work and puts it into shared service models. One of the big problems in healthcare today is the lack of scale and benefit in the back office with respect to what can be done to lower the cost of care and make those processes more consistent. The front end of healthcare is always going to be community-based, and therefore the people who do that best should do that. Look, the other thing is many of the partnerships that we've had for a very long period of time are changing in nature. So we are partnered with Health Trust Partners, which is owned by HCA. And that partnership, as it's evolved, they've brought us a bunch of things. How to source directly from global networks, analytics around our supply chain that we then use to work with our doctors to do better things. So I think the thing is, these partnerships are becoming more strategic, even if in the past they were more transactional. And that's really what we're focused on, which is how can you pick the set of partnerships that are strategic, that are going to drive more value for the outcomes we're trying to get.
Yeah, that's great. And Brian, you're really doing some very unique strategic partnerships with asking different questions and seeing if there's new models out there to move the field forward. Tell us a little bit more about what you're doing there.
Well, we have a series of them, and I like that concept of transactional versus strategic, because I do think we're at a point now where we have to develop these strategic partnerships, and we have to create enough durability in them that we can weather the uncertainty that is coming out of either the federal government or other payer mechanisms in this country. One of the interesting partnerships that we put together was around the insurance for our team members. So we have about 25,000 individuals who are in our self-insured health plan for our employees and dependents. And we had an idea that we needed to actively work with that as an experiment. In other words, how do we create better access to care? How do we create higher quality, better health at a lower cost? And then we decided we should do that with some of our other health system partners, some of whom we compete with. So we put together the Health Transformation Consortium. We announced it about the same time Amazon, Berkshire Hathaway, and JP Morgan announced theirs. So a year later, we now have 75,000 covered lives that we're facing the market with. We've got groups of task forces that are working individually on benefit redesign, looking at outcomes, wellness, how do we work on that? So after we've been in it and launched it January 1, Amazon, Berkshire Hathaway, and JP Morgan named their company. We're actively working in that space now, and that is a unique partnership because it does several things. One is you're working with competitors in a different way. And if you want to try weathering something, do that.
Right.
The second thing is we are impacting our team members universally in a better way, and we're driving down our per capita spending. And now we want to team with employers and do that in the same manner.
So we're going to turn to Q&A in just a few minutes, but I'm curious to get the perspectives, and you can see just the wonderful minds and talent that we have across the hospitals and health systems in the country who are really, in a lot of ways, leading the transformation. I mean, what's it going to look like in 5 years? I mean, are we truly going to be an environment of healthcare without an address, or are we still going to be expecting folks to come to the bricks and mortar or a combination? Who wants to look into that future?
I'm happy to be as clear as I can on that, which is you're not going to get rid of addresses. I don't know I'm not sure even what that means, to be quite honest with you. I mean, the population is growing from the standpoint of Medicare and those above 65. They're living longer. The acuity of illness is growing. The disease burden in those that are, just call it 45 to 64 years of age relative to when I was born, in that period of time, we've got triple the rate of diabetes, 4 times the rate of obesity. Hypertension continues to be a problem. Though we're in a pretty good jobs period right now, I think the impact of stress on lifestyles and other things is creating a greater burden of illness. I don't see the problem being an address where you need health care. I see the problem being access. Mm-hmm. And at least in our environment, making sure that access is easy for people. And when you decide what you're going to provide access to, because again, I think Part of the problem with the industry is that everybody wants to be all things to all people. I think it's a dangerous place to be personally. But when you figure out what you're going to do, then this sort of no address concept becomes relevant, because what you want to do is have that patient family and the way they interact with their physicians or other caregivers not be dependent upon every visit, but give them a sense that they're part of a healthcare community that operates in a way that's looking after them. 5 years from now, we're not going to see the absence of, in fact, we're going to continue to investing in addresses, right? In many ways. Now, those addresses may be different types of addresses in terms of, we're not building 500-bed hospitals, but we're not getting rid of addresses.
Yep.
A little bit different view of being all things to all people and trying to deliver all things to all people. The world in which I operate, the safety net world, we have no choice but to be most things to most people.
That's true.
Because we're talking about primarily Medicaid and uninsured individuals. And those are not necessarily the patients that everyone else is running to bring into their systems. And so we have learned and developed health delivery models over time that have moved toward becoming most things to all of those people that we have to serve. We have to own it stem to stern, or they won't have the access they need. In Atlanta, Georgia, today outside of Grady, if you are unfunded and need a hip or knee replacement and are going to go to another system to do that, if you are unfunded, that's not going to happen. And if you have Medicaid, the average wait for an appointment is a year. If you're Medicare, the wait is 6 months. And so we all play very important roles. We all play very different roles. But we have to look at the fragmentation model versus the more holistic model in different ways based on the niche that we're in.
Yeah, great.
And so 5 years from now, I'm with you. There's still going to be lots of addresses. My hope in the safety net world is there's a whole lot more addresses, but it's not on our campus. We have one of our former board members here, Chris Durvich. He's in a market where they really have perfected getting the care out into the community. In Dallas, Texas, every Dallas school district school has a clinic within it that treats the children and the parents and the family. They have 25 multi-specialty clinics out into the community. They have developed partnerships with the faith-based community and have placed advanced practitioners into most of the large churches to help manage health. So I see those addresses for us becoming very important.
Great. Brian, 5 years from now?
Boy, I don't know. And what I mean by that is the problem we have today is we've got a healthcare delivery system that's predicated on how we're paid.
Right.
And as these payment changes continue to change, that will ultimately show how the system adapts, because we all want to do the right thing. Oftentimes, our payment mechanisms get in the way. So I think there's some variables we have to watch. One is the increasing burden on taxpayers of healthcare funding. UCLA did a study a couple of years ago, it was published, that 65 to 75% of healthcare spend ultimately comes out of a taxpayer's pocket. If you think about military medicine, you think about municipalities, governments, in addition to Medicare, Medicaid, and those things. So the tax burden issue and how we're going to deal with that, I think, is really important. The big issue in this country right now is this shift to payers, or shift to individuals from employers and other payers. The average bank balance in this country is about $3,400. The average deductible in an employee health plan right now is between $1,600 and $1,800. 60% of people in those plans never penetrate that. That's true out-of-pocket cost. So how individual consumers mobilize around that and how we react is something we really have to watch. Because at the end of the day, my hope of what doesn't happen 5 years from now is we have a fragmented system that gets further fragmented, because that's when I think people are going to be hurt.
Well, as with most things at Aspen, you can see the complexity and the challenges that are ahead of us. Look, we do want to open it up for some questions. We don't have mics, so if you could stand up, say who you are. Oh, we do have mics. Okay, sure. Well, actually, you, the gentleman in blue, you had your hand up first.
Great. Good morning. Thank you, everybody. My name's Raj Agarwal. I work at the Jefferson Health System in Philadelphia. My question is around the concept of de-innovation. When you think about healthcare with no address, let's think about cell phones. There are no phone booths now anywhere. When we think about streaming music, you don't have to buy CDs or vinyl records anymore. When you think about Netflix, we don't have to go to the Blockbuster store anymore. When we think about healthcare with no address, the digital front door, innovation, can I ask the panel the assets that their health systems are not going to invest in right now and in the next few years so that we can actually move forward in innovation as opposed to trying to have it all?
Great. Who wants to tackle it?
Well, I think I started that conversation. I mean, look, there's certainly a set of assets that it's not like we're going to be investing in huge inpatient towers all over the place unless the demand is there. And frankly, where we do build additional inpatient capacity, we're going to build for a future in which the utilization on the inpatient side is anticipated to be lower because of technology and service innovation. At the same time, as I described on the other end of the spectrum, we're not going to invest a significant amount in large-scale, broad-based, frontline primary care because we don't manage it well, right? What we're going to do is invest, as I noted, in primary care models that help to take care of those with chronic illness that require complexity, coordination, and the types of things that we can help them with, given the skill sets that we have. The other thing that's sort of missing and not been a part of this conversation is really the huge amount of capital intensity that goes into both the device, technology, and pharmaceutical landscape that really was the primary beneficiary of the dollars post the ACA, right? So if you think about relative to the trend in expenditure in the US, there was about 150 billion incremental dollars injected into the system, 50 billion of which went into the pharmaceutical industry because of specialty drugs and other things that were very expensive. And so there's a whole discussion to be had about what capital investment is going into those business models that's driving a lot of frontline consumption costs that has nothing to do with the care model that exists. And there's a legitimate debate, just like my debate about fragmentation versus integration of care. What is the value of Me Too pharmaceuticals that are newly branded versus truly innovative pharmaceuticals, and how should they be priced in the marketplace? The rest of the world has figured out one model. I'm not sure that model works for us, but that doesn't mean we shouldn't come to a solution. So one of the things that we're going to be very careful about investing in is models in which we can understand delivering and how we'll deliver efficient healthcare without necessarily, contributing to this excessive consumption of very high-priced drugs that generate only incremental benefit.
So maybe what we'll do, because we are going to be running out of time, we'll have ask your question, we'll get the second question, and then we'll have the panel respond.
Good morning, and thank you for a really smart conversation. My name is Jackie Judd. I'm a member of the American Board of Internal Medicine Foundation Board of Trustees. We've recently adopted a new strategic initiative centered around rebuilding trust in the healthcare system, which can be argued is pretty broken. So you all obviously operate in the C-suite. I'm wondering if there are, as you reimagine healthcare delivery, explicit conversations about trust, and if so, what do they sound like?
Yeah, great question.
Thank
Let's
you.
get our second question, and then we can address both.
Peja Stojčić, Ripple Foundation and Rethink Health. We are exploring kind of like working with hospital systems like this changing role that you described. And one thing that we are seeing a lot is that there's a lot of internal problems to change that role, to actually go through that process. I'm just curious if you can reflect on your experience in changing the role of hospitals, how it is reflected internally, and what kind of challenges did you encounter with physicians, providers, and people working in the hospital system.
So enhancing trust in the change process here. Wow. Boy, we could talk for hours on both of those.
Yeah, well, we do have a lot of discussion around enhancing trust, and when we talk with our patients, and we do focus groups continuously, we interact with our patients continuously, because the role we've played long-term in their lives, and over the years, particularly in the South, what that has meant to the population we serve, there is a high degree of trust. There was a session recently about what a living wage means to health, and there was a very important statement made in there that we have a number of our employees, a majority of our employees probably, who are dealing with the stress of life, including financial insecurity and other issues. We have employees that come in and out of homelessness. And what I am more worried about around trust is loss of empathy and compassion toward the patients, because when people, including healthcare workers, are preoccupied with what's burdening them, empathy and compassion can go out the window. And it's real easy, as you said, from the C-suite to say, hey, you need to be compassionate. Well, it's hard to be compassionate when life is overwhelming you.
Brian, you want to have the final word here?
Just a couple things. Yeah, it's really hard. It's very hard. And the real trick is to try to develop a compelling vision about why we need to change. And that's hard. It's adaptive change. It's constant, and it has to start at the very ground level of the organization where people are touching patients. In terms of trust, I think trust is everything, and we erode trust not necessarily in the way we care for patients, because I have so much confidence in our physicians and our nurses and our other team members. We lose trust in the friction that surrounds getting health care. And I think that has to be an important piece. An important part of that is the financial implications of this. Mm-hmm. So in our organization, trust is at the front and center of everything we talk about, and how do we mobilize around that. And I have a phrase, it's like, how do you take the scare out of healthcare? Because there's probably nobody in this room that has any kind of lab test that you're not worried about, right? Even if it's a routine test. So you've got that scary part of healthcare. Well, the new scare about healthcare is, what's this going to do to me financially? And we absolutely have to work together on that, and that is our drug company partners, our payer partners, our communities, our patients, our doctors, our nurses, and our health systems. And that's our challenge, is how do we take the scare out of healthcare?
We spend a lot of time at the association about how do we tell the story differently about the incredible life-saving, birth to death scenarios that you do, the health promotion, to help strengthen that trust and that relationship. And we also spend an incredible amount of time on how do you just get going? How do you change the mindset and start a different dialogue, which is something we spend a lot of time at the association. It's why we're here at Aspen Ideas. We have our AHA Center for Health Innovation is a key part to being a catalyst for the type of transformation that we need to have, as well as our value initiative that really is looking at the best outcomes at an affordable cost. So a lot of activity, a lot of complexity, and that's why we need everyone's bright thinking into how we move forward. But please join me in thanking our panelists.
Healthcare without an address. The idea of reaching people where they are is yet another example of how hospitals are transforming to meet patient needs. I hope you've enjoyed this discussion. You've been listening to Advancing Health, a podcast brought to you by the American Hospital Association.